Hey Anuja, welcome.
Hi, Jai
So, yep,
Jinendra.
Jai Jinendra, if you're ready, we can start. Okay.
Okay, okay. Good evening, everyone. My name is Anuja Mehta, and I'm going to be talking about depression treatment today. Okay, I don't see people, but I guess there are people in the call. Okay,
Suril, can you make Anuja highlight, spotlight, so that everybody can see her?
I think he's doing that, Suril Bhai. Okay. Um,
Just you can wait 1 or 2 minutes, okay?
oh, sure, I can wait. Yeah.
Yesterday we have talked a lot after your discussion, but you were not there.
Okay.
It would have been better if you would there stay there.
So let's have a question answer sessions after your discussion today. Okay,
Okay.
Anuja. So at least if anyone has any questions or something, they can ask you. And I think it's better you can because anyway we are recording it, so no worries to
No,
wait
but
for them.
Suril, you can keep her inside as a side speaker. She must be seen.
Yeah, she is because I already spotlight her, so she is.
But she is not visible here.
I don't know.
Also, the
Okay,
screen share is
Anuj,
showing the
I
presenter
think
has it on.
you are sharing a wrong screen, so you might have to swap display. Yep, now
Thank
you are
you.
good.
Now, where it is good. It is
Okay.
Dr. Dev is being seen in the site.
No, whenever I have spotlighted, then and let me check it up online as well. How this the vision will be look like. Just give me a second, and I'll check it out. Yeah, on online one, yes, I can see her in a site. Okay, so it's a good.
Okay. Thank you, Suril Bhai, for helping with that. So I just wanted to follow up on the conversation yesterday about depression treatment. Um, and so to introduce the topic, and I spoke some of it yesterday. The disease of depression is a global impact. It affects millions of people worldwide, and many of us might know people in our own lives, either family, friends, somebody at work, who may have struggled with depression in the past or now, and it does affect daily
Anuja,
functioning.
sorry, Anuja. Suril Bhai, Anuja is not visible. Please.
Vandami, let me send it out to you a live link, and can you, if you can check on YouTube, if you can see if she is able to see it on a side one, then we are good.
See on YouTube how I can open that.
She is visible to us, Samniji.
Oh,
We
so
can see her and as well as the slides.
okay.
Maybe we need a different link.
Mm-hmm.
Vandami, I already pasted that the link, so if you just click on a chat box and check it out. Okay, so yeah.
Now she is visible. I don't know because of my setting or
No, no problem, no problem. These things happens always been. And thanks for, that means taking care of all those such a small things, and sometimes we miss it. So it's really grateful.
okay, now Anuja, please
Okay, thank you, Samiji.
start again from your title slide.
Okay.
Sorry.
No, it's okay. Okay, so everyone, my name is Anuja Mehta. I'm a psychiatrist. I want to talk today about a little briefly about depression treatment in follow-up to our conversation yesterday about overview. I mentioned this yesterday during my talk that there is a global impact of depression. It's a disease that affects many people across the world by affecting people's daily functioning, their inability to participate in work and school relationships. The goal for clinical management of depression is to diagnose the illness as early as possible and then start treatment. And I'm going to be talking about treatments that we use here in allopathic medicine in the Western world, many countries. So it's very similar between US, Canada, and European nations as well. And then I want to talk a little bit about treatment gap. Despite our best efforts, we still have 30 to 40% of patients who don't improve and continue to experience symptoms. So the roadmap of the talk, first, I'm going to talk about first line approaches. So somebody with depression, if they come to the doctor here in US, what type of treatments can they expect to be prescribed? And I'll talk about therapies as well as medications. Then I want to talk about treatment-resistant depression, which is actually common for specialists such as myself and my colleagues. I want to discuss what that is and other treatments, non-medication related, that we can offer our patients. And then I want to talk, so I'm going to talk about ECT, esketamine neuromodulation a little bit, just show brief videos in case people are unfamiliar with what those are. And then I want to talk about also physical activity, exercise, yoga, and other holistic interventions that are quite effective at treating depression. And based on research, usually mild depression, but also if folks have moderate depression, they can use these interventions and their therapy and medications all together. So I want to talk about first-line psychotherapy. And yesterday, Samniji apologized and didn't stay for the whole time, but I recall that Samniji was talking about negative thinking. And it is true that a lot of people who struggle with depression have negative thinking. It is very negative when you sit down and talk to somebody who's depressed. So there is a role for psychotherapy, and that is a skill-based, it's a professional service where individuals who are psychotherapists or trained in psychotherapy will work with patients or clients to help them shift their thinking so it is not as negative. And the goal is not always that you make the thinking positive. So it's negative to positive, we think of that way, but at least make it more balanced. So reduce some of the negative thinking, try to get to some neutrality, and then you may get to positive thinking or you may not, but at least you're reducing the impact of those negative thoughts. One thing I do want to say is that people in my family and other people that I've known, I didn't always know that I wanted to be a psychiatrist. My family thought I was going to be a cardiologist. They wanted me to do something else. And it's something that I've learned. I've learned to love what I do. But a lot of people, not only Indian people, they will give advice to people or other people who are struggling with anxiety or depression and say, stop thinking negative. You know, you may have heard that. We just need to think more positive. Those types of things are not helpful to somebody who's struggling with depression, and that is not what is done in psychotherapy. And I have my family members who have joked around that, oh, what do you do? And I do psychotherapy, part of what I do. And they would say, oh, people pay you for this. You could just tell them to stop thinking negative and think positive or do X, Y, and Z. And we joke about it, but in all seriousness, just to give you an example, when I would sit down with a patient and I would do psychotherapy, you almost never, I would never use the phrase, don't think, fill in the blank, whatever the negative things they're thinking. So if you are going to do CBT with a patient, for example, cognitive behavioral therapy, we start off by talking a lot about what depression is. So that phase is called psychoeducation. So you're telling the patients what depression is, how they get to be depressed, and you can explain different for each patient individually, if their family history or their personality traits, etc., or their life circumstances. Then you tell them what CBT is. You have to give a little bit of description of cognitive behavior therapy, what we're going to hope to achieve, and then you sort of give them the roadmap of what you're going to be doing with them. CBT specifically is very technique focused. So there's worksheets that you can do. You can work with the cognitive. So you have to first elicit, means try to figure out from the patient what they're thinking distortions are. They have distorted thinking patterns. So you ask them questions and say, tell me what happens, how did you feel, etc. And they'll tell you, and then you can kind of create a sort of a description or summarize for them and explain to them what their problems are. And then you sort of describe to them. One example is catastrophization. So I'll give you an example. People go to medical school. I went to med school. A lot of young people, they take an exam and they feel they're convinced they have failed the exam. But then it turns out they haven't failed the exam. They did really well. So while they think they failed the exam, they're very stressed out. Maybe they're depressed, they're sad, and all of this is temporary. It's just an example. So if somebody struggles with this type of issue a lot and it severely affects them, then you can show it to them that you're engaging in what we call catastrophic thinking. So you're engaging in catastrophic thinking. We're going to help you find balance to that. And then there's different exercises you can do. And usually what you do is you ask them, what is the evidence that you have failed the exam? Can you give me? Let's write it down. And so they'll write it down, because it was too hard, this and that. And then you would ask them, what is evidence that you passed the exam? Because they've never thought of that. They're only thinking all the negative. And so they'll say, okay, I've studied for the exam. Well, how much did you study? Well, I've been studying for the last month. How many hours a day? Well, I study for 15 hours a day. Okay. So how likely do you think somebody who studied 15 hours a day for 30 days, how likely is that person to fail an exam? And then they'll say, not very likely. Have you failed other exams, right? How have you done in high school, in college, etc.? And then they can see that their thinking is a little extreme. They have not considered evidence to the contrary. So that's just an example of CBT. Interpersonal therapy is another one which focuses on depression that stems from relational issues. That can be very common to a lot of people. So they have struggles in their marriage, with their parent, workplace setting, with their child, anybody. And again, there's the tendency to misperceive what's happening in a relationship. Oh, my mother-in-law said this to me. She hates me. Well, what is evidence that she hates you? What did she say? When somebody else says something like that, what is that? Could it mean something else? So you're almost always, you're investigating what they're thinking, you're working with them, and you're helping them help themselves. But we almost never just say in the session, don't think negative or don't think this or don't worry about that and everything will be okay. Because obviously then you're not really having therapy. And I just say that because people in my family, maybe sometimes I have been guilty of saying those things offhand to a friend and, realizing that these are very formal treatments that require a lot of training and people get paid to do this work. People charge a lot of money who are very good therapists. There's other types of treatments. Behavioral activation, that's a really good one when somebody's really depressed and won't leave their house. So we actually will write in a prescription pad, go for a walk or go get, your nails done, go get your hair cut, go watch a movie with a friend. Problem solving therapy is another one. And you can use psychotherapy alone for mild cases, sometimes in moderate cases too, if you have good response to therapy and somebody's very engaged. And even if somebody has severe depression, then you can still use therapy with other treatments as well. I've talked about this last week when we were talking about anxiety. Most of the medications are the same, whether you're treating anxiety or depression. And the reason is because they're all acting on the same neurotransmitters in the brain. And I described the circuit. That being said, anxiety and depression are not the same things. They're different things. And people often will ask me, you have same exact medications. Why? Why are there? And I think the answer is because we don't really fully understand really how brain generates these syndromes. And so these are the medications that seem to work for both. But again, the anxiety and depression are different conditions. So selective serotonin reuptake inhibitors, SSRIs, and norepinephrine reuptake inhibitors, SNRIs, they're the primary treatment. Somebody who I would see as a patient, I would prescribe these medications if they came to me with moderate to severe depression. So again, very depressed, affecting their ability to function at work, cannot work, cannot go to school, just are not able to do what they need to do, significantly affecting them. And they have tried therapy, it hasn't worked, or it hasn't worked enough. And so in those cases, you can obviously use medications. And even worse than that, if patients having a lot of depression and suicidal thoughts, then you can use these medications also. There's other medications, just briefly, tricyclic antidepressants. These are older medications, they have a lot of side effects. We don't use them very much, but they can be used. And then I just put some names here: mirtazapine, atypical antipsychotics. They can be used for augmentation. And augmentation just means one medication doesn't work, we give a second one. And it's very common if you think about like blood pressure management. So that's a very common thing. A lot of people have problems with blood pressure who are older, and they need 2 or 3 different types of medication. They affect different areas. In the kidney, some in the brain, with the heart, that's for blood pressure. So with depression, it's the same sort of thing. They affect different receptors in the brain. There's limitations to medications, just like with any medication. You take an antibiotic for strep throat, you can have side effects. So these medications also have side effects. And I didn't have a separate slide, but the common ones for these are they can cause nausea, they can cause trouble with GI distress, upset stomach. Some of these antipsychotics, they can cause weight gain, so they can cause side effects, but a lot of people do well with them and it can really improve their symptoms. So, they're still worthwhile. What we end up doing for a lot of patients, the best recommendation is, and it says here, power of combined therapy. So you want to do both. We want to help them improve their thinking and help them with adaptive thinking. So again, not necessarily replacing negative thoughts with positive thoughts, but adaptive thinking. So their thinking is not hurting them. And give them medications that can help them, especially if it's moderate to severe depression. So they're really, really kind of struggling with that. And this approach addresses, again, as I said, high severity symptoms more comprehensively than either modality alone. So I'll leave this at that. Then I want to talk about treatment-resistant depression. We see that a lot. About 40% of patients that we see in clinics do have treatment-resistant depression. What that means is clinically that they have failed at least 2 trials of medication. So they were given medication at a good dose for a good, period of time. They actually took the medication. That's another thing. We have to make sure somebody's taking the medication, not just telling you they are, but they're not. They did all that, they did therapy and still they have problems. They still have symptoms. So that's called treatment-resistant depression. The next step is you're going to go beyond the standard care to more intensive advanced interventions. And so I want to talk about a few of those. And before I kind of talk about these advanced interventions, I just want to address another element when it comes to depression. I've kept saying the word that depression is a medical illness, but even in the community that I treat, there is not always full appreciation that it's a medical illness, with this thought that maybe it could be better. They just have to shift their thinking. And I have a lot of people who are religious also who feel that in their community, depression is not viewed as a medical illness by some of them, not everybody. And I think that's very important to take a step back and realize that sometimes with a lot of people, their thinking is negative and you can help shift their thinking and they're going to feel better. But for a lot of other people, even if you help their thinking and make it more adaptive or at least neutral and take away some of the negativity, that still may not be enough. Like they're still going to have symptoms, they're still going to struggle, and you still have to help them out. And one analogy that I use sometimes with my students early on is not a perfect one, but somebody who does not know how to swim. So water is neutral, but if you find yourself in water, in front of you, behind you, above you, below you, that means you're submerged in water. One of 2 things will happen. Either you swim, you move your hands and legs and you get out, or you'll drown. And so that's somewhat helpful way of thinking. One of the way of thinking, at least I will tell people, is you're drowning, and severe depression with suicidality is sort of like that. So if your people, or if your family members, if somebody is telling you, hey, start moving your legs, or, start kicking, and, you got to like breathe in and, make bubbles and those sorts of things while somebody's drowning, that is not very helpful. That's not a good way to learn. And the first thing that needs to happen if somebody's drowning is you got to get them out, lift them out of water, make sure they're okay. And then you can teach them. People can learn how to swim. And I learned how to swim as an adult a few years ago. And you want to do it safely. So you basically start with shallow end, you put your toe in a little bit, you're exposed gently and your swim instructor is with you. And that's kind of what we think of therapy. But that can sometimes help even with my patients who are reluctant. And I'll give that analogy and I'll say, look, if you're drowning, you need help. Like you're not going to be able to do anything and learn adequately how to manage your thinking or behavior. So once you're better, then you can learn those things. And that's true for all these patients that we see as well. One of the treatments that has been newer in depression is actually a treatment where it looks like Flonase. So if people have allergies, they basically put a nasal spray. It's esketamine. And so ketamine is an anesthetic drug that's been used for a long time in the field of anesthesia, but people figured out that when you give ketamine, it can induce euphoria, meaning feeling really, really good. And now they've isolated the substance esketamine, which is FDA approved to treat treatment resistance. So you put it as a spray on your nose, and it helps immediately with reducing suicidality. So that's a very promising treatment, and we can use that for patients who are struggling. I want to talk briefly about ECT, electroconvulsive therapy. Maybe people have heard of it or not. It is extremely effective, 60 to 80% response rate. And the remission rate, remission means that people have no symptoms. So that's what remission means. If you're remission from your depression, that means you don't have any depression symptoms, you're fine. But depression is a chronic illness, you can get it back again. So that will be recurrence. But a remission means that you have no symptoms, and that's very good. That's kind of what we want. When do we use ECT? We use it for severe MDD, catatonia. And catatonia means that somebody's unable to walk or eat, in a severe state of basically brain going, not dead, but just not responding. It kind of needs shocked. And then cases of acute suicidality. And I don't want to go into too much detail today, but ECT, it's unclear how it works, but we do know some of the molecules that it changes, sodium, potassium. And the best way that people have kind of talked about it is your phone freezes, your computer freezes, and what will somebody tell you to do? The tech person you call, they'll say, hey, have you tried shutting it off and turning it on? Turn off the power source, turn it off completely, and turn it back on. And a lot of time that will solve the problem. And the same with iPhone. It's acting weird. Turn the iPhone off completely, wait 10 seconds, turn it on. And that's similar to what we're trying to do with ECT. You're inducing a seizure in the whole brain. And we think you're just turning it off, turning it back on, and maybe we'll fix things. And actually does end up fixing things. So I think I have one more slide. Here's the YouTube link. You have to do ECT for a period of time. So it involves 6 to 12 sessions. And you do it over 3 to 6 weeks. You have to drive to the hospital to get it. And that's why it's not so readily available. There's some involvement, you have to take time off from work, etc. It's associated with significant decreased hospitalization rate and suicide risk. And the side effects is minimal. It just causes a little bit of headache and some temporary cognitive memory issues, but it does get better with time. And not everybody can get it. There's a whole workup. You have to have EKG and other things to make sure that it's going to be safe for you. So with that, I want to, it's here. And the video that I'm going to show you, these are real doctors, the CHI Health, that's out of Nebraska, Omaha. So these are real doctors that are talking about this treatment.
Hello, I am Arun Sharma, psychiatrist and a medical director of the Behavioral Service Line, and we are going to talk about what is ECT, also known as electroconvulsive therapy treatment.
Electroconvulsive therapy, or ECT, is one of the most effective treatments that we have for severe mental health problems. We do the treatment by applying a small current of electricity to specific areas of the head of the patient and their general anesthesia. It is one of the safest treatments that we have in psychiatry. Efficacy of ECT is in the range of 60 to 80% for most of its indications. There is a lot of stigma in relation to ECT, which mainly comes from misinformation or false information.
ECT is used primarily for treatment-resistant depression. However, it is also used in other mental illnesses, such as bipolar depression, bipolar mania, catatonia, where a rapid response is required, and mental illness during pregnancy. Our patient is asked to not eat or drink at least 12 hours prior to treatment. After arriving at the procedure center and completing a check-in, an IV is started and our patient meets with our anesthesia team and psychiatrist. Our patient is then placed under anesthesia and a paralytic to begin the procedure. A small current is passed between two stimulation pads, signaling the brain and inducing a 30 to 60-second seizure. Once the seizure is complete, the anesthesia medications wear off and our patient wakes up about 3 to 5 minutes later. They will spend some time recovering and then discharged home.
One is a candidate for electroconvulsive therapy treatment if the medications are not working to treat their depression or bipolar disorder or other mental illnesses for which they may be appropriate for it. It is also used when a quick and speedy response in a person who may be in a vegetative state, where they have quit eating, quit sleeping, and generally have given up hope on life. In those instances, especially if the medications and psychotherapy have not worked, ECT may be the best option at that point.
Okay. And I'll share back. Okay. And then just want to talk about briefly, there's a newer treatment. It's not very new. It's FDA approved since early 2000s, 2008, and it's been used a lot since then. TMS, which is transcranial magnetic stimulation. And you tell you, the brain conducts electricity, and we kind of know that, which people can use, to their advantage, in meditation. But that's what this therapy takes advantage of, the magnetic currents of the brain. And so you put the TMS machine over a peak person's head, they sit in a chair and induce a current that will go into a specific area of the brain. And again, that rewires or kind of stimulates different circuits in the brain, which can also help with depression. So real quick, just want to show a very brief video with that, just so you can see what that looks like. And this is out of UC Davis, that's in California. So they briefly will talk about that.
Treatment-resistant depression is generally defined as depression that hasn't gotten better with trying 2 antidepressant medications. We know that after a person has tried 2 medications and has not improved, their chances of responding to a 3rd or 4th medication are much lower. We're excited to offer transcranial magnetic stimulation, or TMS for short. This is a non-invasive treatment that uses gentle pulses of magnetic energy to stimulate nerve cells in the brain. It works very differently than standard psychiatric medications, and it can work even when medications haven't been effective. When a patient comes in for TMS, they sit in a chair that looks a lot like a dentist's office chair, and we place a magnetic coil over a specific area of their brain. That magnetic coil generates gentle pulses of magnetic energy that will stimulate the nerve cells in that region of the brain. So when these gentle magnetic pulses reach the surface of the brain, they cause the nerve cells in the brain to fire and send a signal. What that does will depend on what part of the brain you're stimulating. For example, when we place the magnetic coil over the motor area of the brain and we send one of those pulses, we can send a signal from that nerve cell all the way down a patient's spinal cord, down the nerves in their arm, and cause movement in their hand. Yes. For depression, we're treating a different area of the brain that's involved in regulating attention, thinking, and behavior. TMS is also helping to rewire the connections between that area of the brain and deeper regions in the brain called the limbic system.
Okay, so in the interest of time, I will go back here. Complementary care exercise has very good research data on helping with depression, so it's strongly recommended for all patients who are able to. Aerobic activity, resistance training, just even walking, being out in the nature. And actually, in the newest evidence-based recommendations out of Canada for depression, it was a standalone intervention for mild cases. So it's a very strong evidence base for exercise. Yoga is also used as an evidence-based adjunctive treatment. There's moderate effectiveness in reducing symptom severity, no adverse events, which are side effects. And one of the recommendation was to use it as a complement and not replace professional psychiatric care, especially for people who have moderate symptoms. And then other complementary approaches are acupuncture. Some of my patients find acupuncture helpful too, and they use it with medications. I talked to yesterday light therapy, so there's a light box that can be very helpful for people who live in areas that have lower sunlight during the winter and fall months. And then mindfulness, meditation, and mindfulness-based interventions. And there's formal mindfulness-based therapy. So there's mindfulness-based cognitive therapy, MBCT, and mindfulness-based stress reduction that have been derived from principles from Buddhism, actually. And John Kabat-Zinn, he's a researcher out of University of Massachusetts. He was one of the first ones years ago that kind of brought mindfulness-based clinical interventions to US. And a lot of them have developed since, and there's a lot of research and data on those as well. And so that's really it. Just guidance for wellness professionals, just recognizing signs and symptoms of a student or somebody you're working with or helping, or you're doing yoga training if you're seeing something that concerns you regarding depression. Obviously, you should do what you're able to do and refer them for more professional help if that's what is needed. And then takeaways, again, treatment has to be individualized, evidence-based. Each patient is a little different what they'll need. I'm going to work with them. You can do talk therapy early initially. If that helps, that's great. But if that's not enough, then you have to do more things. You can do meds and other interventions. Yoga and exercises are very, very helpful. And we recommend them for everything. And just saying, one thing, it's not just meds that's going to help you. You have to change your behaviors and do things that are going to promote your own mental health. And so that's it. So references. Okay. Well, that's it. I'm sorry I went a couple minutes over, but I'm happy to do any discussion or take questions.
Thank you, Dr. Anuja, for explaining the medical treatment which is being given to the patients of depression. And you have also mentioned that yoga and meditation can also help it in this matter. And I can say that for depression, meditation and yoga and positive thinking, these are very great tools. And they can help without any kind of financial, what we say, burden. So yeah, it is true what you have discussed, and it is very good that we have got all the updates, whatever is going on in the field of medical science for dealing this problem. Okay, so anybody has any questions? Do you think that there should be some change in the lifestyle of the patients? Because maybe because of the loneliness or having no supporting hands to them, and that's why they are going into depression.
Yeah, I think that's something to consider. Loneliness has been declared as an epidemic in US, especially among older adults, because in US, unlike in India and other countries, even though in India it's changing, there's not a tendency for multi-generational living, right? Like people are going to live on their own. So as they get older and one spouse is deceased, people are lonely. And that can certainly contribute to depression because we are social animals. We're not meant to just be by ourselves, the whole time. And in that case, there's a lot of groups out there who have check-ins or social companionship. There's retirement communities where, you're living in communities where there's all built-in socializing and, group meals and those kinds of things. So I think so. I think in some cases lifestyle can contribute to depression and changing it can be very helpful. So yeah, I think Samniji, you're right.
But also, I think it's also important to consider that there are many people who are living on their own and they're not depressed, right?
Oh, of course. Yes.
So it's not being on
Absolutely.
your own only that makes you depressed. But if you are
Right.
depressed, then I think being on your own can make it worse.
Yeah.
But the other thing Devon was talking about yesterday, Anuja, and I don't know, you weren't there towards the end, was that second line immigrants are having a higher incidence of suicide and depression in this country. Is that correct?
Do you mean to say like people born here, like individuals
Yeah,
born here?
born here
Yeah,
to
that's
immigrant parents. And we're
yeah.
wondering, why is that the case?
I think we've talked a lot about that. It was a little bit of older data that basically had discussed about acculturation. So we talked about acculturation when you come here when you're an immigrant. And so when you come here and you have had some time in your in host country, you know the language, you sort of have a sense of belonging. And then you come to
Right,
America, and then, there's these concepts. Are you part of the salad bowl? Or are you part of like the melting pot? So you're kind of all mixed
correct.
in, or you have your own identity, or you're adopting this identity. I think the issue with the second, third generation is sort of confusion. Am I American? Am I whatever it is, Mexican, whatever country you're from? And to what degree am I either or both or neither? And so I think that is not absolute. I think it depends on a lot of other factors,
Mm.
including kind of the home environment they're growing in, their exposure and modeling of their home, their home culture. And do they see it in a positive light or not? And you hear all these stories like, oh, my mom would pack me like ethnic food for lunch, and it was very embarrassing, and I never wanted to eat it. I never want to eat that food ever. Like, those are just some stories. But I think that's the issue, that they sort of, the
Don't fit in
summarizing
anywhere.
neither here, neither there. I'm neither here,
Mm.
neither there sort of thing. But that's not everybody. I think there's a lot of other nuances to that I think you have to consider. Socioeconomic factor is a huge one. So again, you have a family that's very wealthy. It's going to
Mm.
be very different than, folks who are working families and working parents, and, what climate, what environment they live in, what demographics, all of that. So,
In the second generation population, you're
yeah.
saying? Yeah,
Yeah. Yeah. So their
interesting.
parents.
I mean, it
Yeah.
was just a surprise that it was so high, that it was
Yeah.
the rate was high.
Lacking of proper parenting, that is also one of the issues.
It could be. I think that it's really hard. I'm a child psychiatrist. I have a lot of compassion for parents. I really do this because I like to work with parents. But I think you have examples, which is in Indian culture, any other culture, parents are working 2, 3 jobs. They're a gas station, they're running a motel from like 5 a.m. to, 11 p.m. and the kids are on their own or with neighbor. And is it really their fault? I mean, they're trying their best to survive. And regardless, those kids are neglected. They're not getting their parents' attention. And that doesn't mean most of them will struggle. I mean, most of them end up doing fine. It's just that a small percentage of them, it's going to have a negative impact on them. So I tend to think the parents always are trying to do their best. I mean, there's probably very few tiny, tiny percentages actually trying to sabotage their children. But I think a vast majority come from a good place. They want to help their kids, and it's just resources. They don't have that. They're in a tough situation. And that can definitely have an impact. And so I said socioeconomic, those things play a huge role in this, the second generation. So it's not just automatic that you have second generation and they're going to have problems with depression. I think so many factors are at play.
And what is the prevalence of depression in India and anxiety?
I'll have to look
Do you
up
know?
in
I was just
who.
wondering, is it lower than here?
I don't think it's lower. I mean, I think it's probably undetected. It's not.
Yeah, it's like ADHD, that if you went there and you look for it, you'd find it,
Oh,
right?
yeah, for sure. It's
Yeah.
underreported, vastly underreported. Yeah.
I think that's the thing with some cultural backgrounds that
Yeah.
don't not approve of it, don't accept it as a diagnosis almost.
Yeah.
Won't, just like you said, that they'll say, oh, you just have to change your thoughts. And somebody is right. I mean, if you think like that you change your thoughts and you would become more positive, it would help. But then if you, like you were saying, that if you're really depressed and you just keep saying that, then it's not helping them.
Yeah, it's not helping them. And I didn't mention this here, but years ago when I was a med student, they showed us a video. It was a real video. It was an older video. It was filmed in San Francisco. And people may have heard that there are certain places which are known for committing suicide. I mean, it's unfortunate,
Yeah,
but
the
Golden Gate Bridge is a big
Golden
one.
Gate
There's some in
Bridge. Yeah,
Japan.
yeah.
And what they did in 80s or 90s in Golden Gate Bridge, they actually built all these nets for help people. So even if they jump off, they're going to
Yeah, they fall in the net,
So
right?
some people fell in the nets, then they interviewed them.
Mm.
And so this was an older video, and they interviewed them, and there was one person, I remember this, and I didn't know at the time that I was going to be a psychiatrist. I was first year med student, and it was some class. And they interviewed this man, and he said, oh, thank God they were like, how do you feel now? And, and then they take them to the hospital after they fall in the net. And he said, thank God for this, because when I decided I wanted to jump off, things were so bad and my mind wasn't working right. I wasn't thinking right. And obviously, once I got treatment, I want to live. Obviously, I want to live. And one of my attendings that I had told me or conceptualized depression, severe depression, suicidality as a hijacking of the brain. Your brain's hijacked completely. And so every thought is just completely messed up, right? It's not a normal thought. That's not what most people would have. And that same video, there's another example of a woman who had tried to have a suicide attempt and survived, and that wasn't through jumping. And she had said, people would often say, oh, you have kids, why do you want to kill yourself? That makes no sense. Aren't you a good mother? And normally we would think that having children is protective and believing in religion is protective because you believe in a higher power, and some religion commit suicide is a sin, etc. And she had said, when I was feeling that depressed just before I had my attempt, my constant thoughts were, I'm a horrible mother. And if I'm not here, then my children will be better off. They'll be better off without me. And those were her constant thoughts. And so you can see, and then obviously when she got treatment, she was interviewed, so she had improved and she was, doing much better. She was a good mom. It illustrated to us at that time that is a hijacking of your brain. And if you've never had that, you don't really understand what that feels like. Every thought that's coming into your head is just, abnormal, extremely negative, and it's not really you have any control over it. It's almost like somebody took over.
Hijacks it.
Like a virus takes over your computer, like completely hijacked. There's nothing you can do. Things are being typed, websites are being hacked into. I mean, if it's not completely hijacked, then maybe you can help them a little bit. But when you're kind of at that total point, and so when we train, we have inpatient psychiatry rotations, and those where physicians know the involuntary hospitalization, and there's always an ethics debate. You're taking away somebody's right and saying you cannot make decisions, an adult, and I'm going to put you in the hospital. No other field in medicine does that. You have a right to say no. The reason we've done that, and it always stands, is because we feel that person's lost their thinking. I mean, if you want to kill yourself, you don't know what's going on. Your thoughts your brain's hijacked. We are going to just step in and take away your rights for a period of time until we can kind of get you back into thinking more normal. And so as a society, we approved that. In America, every state has some version of involuntary commitment. So I think it's important to understand that when people are going through that, you can't talk them out of it. That is not something that's a negative thinking piece that they can just turn into positive thinking. Most people you can talk and they can help, but in this, the situations that I'm talking about, it's just their brains just taken over. So at that point, all you can do is help them. You inpatient, you give them some medication, you can do some ECT, and eventually, they can start thinking more normal and it can come back.
Your figure of 40% are multi-resistant, are treatment resistant, multi-treatment resistant. 40%. I was quite surprised at that high number, and it made me think that in that situation, either it's so severe that then it's going on to your other treatments that you're talking about, or they're having too many side effects and that yoga and
Yeah.
meditation might be a better option for them.
Yeah, I think at that point, you're basically what we call you throw the kitchen sink at them. You're throwing everything, well,
Just giving
clearly things
everything.
haven't worked for you. Let's try everything. And then it depends if people have resources, like if they have money, they'll go in this beautiful, idyllic inpatient settings. McLean was one of them in Boston, where I did, some work. They have in Virginia, and basically thousands and thousands of dollars, and you have 4 times therapy, 4 different
Therapist.
therapists that will meet with you, and you have art therapy and music therapy and pet therapy dogs and meditation and mindfulness and all of that. And that can help some, but yes, we will, there's different reasons that I didn't go into. Some people have personality disorders, so those are very resistant to depression. There's
Treatment.
different reasons. Sometimes there's substance use, you didn't pick that up. So there's usually we can figure out why that's the case, and you can help them figure out their individual treatment.
Thank you.
Yeah.
Thank you very much, Anuja, for good discussion and talk. Okay, so thank you very much. Now, Shachi will give session.
Hi, everyone. Yes.
Thank you, Anuja.
Have enough time for giving full session.
Okay. So today we'll do the full meditation with the perception of psychic colors. Before we go ahead and start the meditation, I want to give a quick little explanation about the overview of that and why we do it. So the idea is that our body is surrounded by
You can sit in a proper position so that you can be visible.
Me?
Yes.
Is this good?
Yeah, you can be a little bit up. You can be a little bit up.
A little what?
Yes.
Okay. So our body is surrounded by a colored envelope known as aura, and those auras are continuously changing based on our attitudes and our emotions. And there's a close relationship between those three. So we can purify our aura by purifying our attitudes and our emotions. So in this present exercise, what we're going to do is going to use the power of visualization and focus on a particular color and its particular psychic center. Then with mental projection, we're going to visualize that color spreading all around us and permeating the whole aura. Lastly, we're going to use the power of autosuggestion to bring about a change in our emotional patterns and our attitudes. And we'll do all this while maintaining deep concentration and alertness throughout the meditation. So now, we'll go ahead and get started. So please get seated comfortably. Your posture should be either in the full lotus, Padmasana, the Ardha Padmasana, the half lotus, or just simply seated with your legs crossed. Go ahead and place your hands either in the Gyan Mudra or the Brahma Mudra. So for the Gyan Mudra, have each hand on the knee, palms facing up, your thumb touching the index finger. For the Brahma Mudra, have again both hands, the palms facing up, but the hands inward around the navel with your right hand resting on top of your left. Go ahead and slowly close your eyes, and we're going to say Om 5 times. Om. Now with your back straight, your body steady, we're going to go ahead and begin the relaxation. Breathe slowly and deeply. Feel your entire body relaxing. Now, focus on the big toe of your right foot. Suggest that the muscles and the nerves of your right toe relax. Experience that toe relaxing. Feel that it has relaxed, and then move on to the other toes of your right foot. Suggest that the remaining toes also relax. Feel the toes relaxing. Then the sole of your foot. Suggest that the heel relax. Next, move on to your ankle. Feel the right ankle relax. Suggest that your calf relax. Relax. Feel that the right knee is relaxing. Suggest that the nerves, the tendons, the joint around your knee relax. Release any pressure or tension that it may be holding. Move up to your thigh, your quads, your hamstrings. Suggest that it all relax. Release the tension. All the way up to your hip joint. Suggest that your whole right lower limb relax. Then focus on your left big toe. Experience your left big toe relaxing. Suggest to your left toes that they relax. The nerves. Feel the toes and the nerves relaxing. Move on to your sole, and slowly work your way up to your left hip. Suggest that the nerves, the muscles, the joints of your left limb relax. Feel that your lower limbs have relaxed. Focus your attention to your lower back. Suggest that the muscles and the nerves of your back relax. And then focus on the front. Feel your muscles, your nerves, your abdominal muscles, the inner organs relax. Focus on the right side of your abdomen. Feel the muscles and nerves relax. And then move to your left side of your abdomen and do the same. Focus on your rib cage. Work your way up your vertebrae. Feel each rib cage, each rib relax. As you work your way up to the chest, feel your chest muscles relaxing. Your lungs and heart inside as well. Work your way up to the collarbone and the neck. And slowly feel that your whole torso has relaxed. Then focus your attention on your right thumb. Suggest that the thumb relax. Feel the muscles and the nerves relaxing in that thumb. Relax. Relax. And then move on to the remaining fingers of your right hand. Suggest that they relax. Move to your palm, your wrist, and then your forearm. As you gradually work your way up your arm, suggest that all the muscles and nerves in that region relax. As you make it to your right elbow, suggest that the muscles and the nerves attached there in the joint relax. Relax your right arm and the shoulder. Focus on each part of your body. Send the suggestion to relax and feel that relaxation occur. Then move to your left thumb and follow the same process with your left arm all the way up to your shoulder. Suggest to each individual part to relax. Feel the muscles and nerves of that body part relaxing. Slowly work your way up through the joints up to your shoulder. Now, once everything is relaxed, up to your neck. Focus on the head and neck area. Relax your neck, your throat, your chin, your jaw, your mouth, the lips, your cheeks, your nose, your eyes, your ears, your forehead, all the way up to your scalp. Feel your whole face and neck relax. Now, take a quick journey from the top of your head down to your toes. Notice that everything has become relaxed. Next, With your mind's eye, visualize everything around you, including the air. Visualize everything around you, including the air itself, is the color green, specifically bright emerald green. Take a deep breath, and as you slowly inhale, visualize that even the stream of air that you are inhaling is bright green. Repeat this for several breaths. Now, focus your mind at the center of your chest where your heart is. That's also the Anand Kendra, the center of bliss. Try to visualize a bright green light emanating from that region. Visualize this bright green light radiating from the center of bliss. Then visualize that this green light spreads through your back. And if the light disappears or it does not appear at first, that's okay. Don't be disappointed. Try again and try to intensify your efforts to visualize the green light. Now, visualize that the green light emanating from the center of your chest radiates outwards and through your whole body, and then out past that, permeating the air itself. Visualize that you and the whole aura around you is encompassed in a bright emerald green light. Take several deep breaths visualizing this. Now, you're going to repeat the following sentence 3 times. My emotional pattern is being purified. My mind is being purged of all negative attitudes. My emotional pattern is being purified. My mind is being purged of all negative attitudes. My emotional pattern is being purified. My mind is being purged of all negative attitudes. Next, with your mind's eye, you're going to visualize that everything around you, including the air itself, is bright blue, like the color of a peacock's neck. Take several deep, slow breaths, visualizing that the air itself that you're inhaling is bright green, bright peacock blue. Now, focus your attention to the center of your throat. That is the center of purity, or the Vishuddhi Kendra. Visualize that the bright peacock blue light is emanating from the center of your throat. Perceive the bright blue light to radiate out and encompass your body and the air around you. If you lose the blue light, that's okay. Go ahead and try again to maintain that bright blue light encompassing you and the aura around you. Now we're going to repeat the following sentence 3 times. I realize my desires are being brought under my conscious control. I realize my desires are being brought under my conscious control. I realize that my desires are being brought under my conscious control. Next, with your mind's eye, visualize that everything around you, including the air itself, is red. Bright red, like the red of a rising sun. Take a slow, deep breath and visualize that the stream of air you're inhaling is bright red. We're going to repeat this for several breaths. Now, concentrate on the space between your eyebrows. This is the center of enlightenment, the Darshan Kendra. Visualize a bright red light emanating from this Kendra. Visualize a bright rising sun red light emanating from the center of enlightenment. If that light doesn't appear or it vanishes, don't be disappointed. Take a deep breath and try again. And intensify your efforts to maintain the visualization. Now, visualize that the bright red light is spreading and encompassing your whole body, and then slowly permeating the air around you. Visualize that you are encompassed in an envelope of red light. Now repeat the following sentence 3 times. I realize my power of intuition is developing. I realize my power of intuition is developing. I realize my power of intuition is developing. Next, with your mind's eye, visualize that everything around you, including the air itself, is bright yellow like a sunflower. Take a deep breath, and as you inhale, visualize that you are breathing in long streams of bright yellow air. We're going to repeat this for breaths. We're going to repeat this breathing exercise for several breaths. Now we're going to focus on the top of our head, which is where the center of knowledge or the Gyan Kendra rest. Visualize a bright yellow light projecting from the top of your head. Now, visualize that that yellow light radiates outwards to encompass your whole body and the air around you. Visualize that everything around you is bright sunflower yellow. Next, we're going to repeat the following sentence 3 times. I realize my perceptive capacity is increasing. I realize my perceptive capacity is increasing. I realize my perceptive capacity is increasing. Now, one last time, with your mind's eye, visualize that everything around you, including the air itself, is the color white, like a full moon. Take slow, deep breaths, and as you inhale, visualize that you're inhaling streams of bright white light. Repeat this for several breaths. Now concentrate on the middle of your forehead, which is the center of insight, or the Jyoti Kendra. Try to visualize a bright white light in that region. Visualize the white light projecting from the middle of your forehead and expanding to encompass you, your whole body, and the air around you. Visualize that the bright white light is emanating from the Jyoti Kendra and spreading all around. Next, we'll repeat the following statement 3 times. My anger is waning away. My emotions are being pacified. I feel complete tranquility of mind. My anger is waning away. My emotions are being pacified. I feel complete tranquility of mind. My anger is waning away. My emotions are being pacified. I feel complete tranquility of mind. With this, we will begin to conclude our meditation with 2 deep breaths. Followed by 2 Om Shantis. Now, slowly rub your hands together, place them on your eyes, and then gently open your eyes.
So how was the meditation?
Yeah, it was really, really nice. Such a
My
really, really nice job.
video is
Good
not
job.
working, so yeah.
That's very nice.
Thank you.
Yes. So thank you, Shashi.
Thank you,
It
Sachin.
to give meditation before we have to introduce little bit. So you have done. You have introduced very well. Yeah. So that is good. So that people can be more concentrated if they could come to know the why we are meditating.
It was very good. Shachi, you have a very soft and melodious voice. And
Thank you.
the only suggestion I have is we need to make the resolution when we get into the meditation. Because this Preksha line of meditation is different from others, we do need to specify that this is Preksha meditation. So in your resolution, you will be able to do that. When we do the resolution, we are practicing Preksha meditation for the purification of our psyche. So that separates us, I mean, this type of meditation, this line of meditation from other meditations. It's the only suggestion I have.
No, definitely. Thank you. I said that yesterday, I think. I definitely forgot to say that today. So thank you.
You can raise a little bit a voice so that everybody can listen to you.
That's also.
Yes. It was good and melodious, but still, if it would be a little bit louder,
Okay.
it will be good to follow the instructions what you are speaking.
That's right.
Yeah, it was very good, Sachi. I mean, I was just actually very impressed that you maintained your pose or voice or whatever, like through this long meditation, like continuing through all the colors. It was really good.
Thank
And
you.
keeping everything in mind, no?
Yeah, to keeping it all in mind and to
That-
staying.
right.
Yeah, it really helped me to stay focused.
Yes.
Thank you.
Thank you.
Okay. Thank you very much. So
But
be
then
ready
I'm gonna find some music. Kutulis.